Well, ladies and gentlemen, welcome back again. I hope you didn't mind having a somewhat shortened lunchtime, but we're going to continue. An absolutely fascinating morning we had with the discussions this morning, and it's going to be just as good this afternoon. So let me begin by introducing Professor Ibrahim Abubakar, who is Director of the University College London Institute for Global Health. He's an Honorary Consultant, Public Health England, and an Honorary Professor at the London School of Hygiene and Tropical Medicine. And he's had a career with leadership roles spanning clinical, academic and public service life. He's currently chair of the WHO Main Advisory Group for Tuberculosis, that's the Scientific Technical Advisory Group, TB, and chair of the Wellcome Trust Population Health, ERG. And he's chaired the UCL LANCET Commission on Migration and Health, and this, of course, is what he'll be talking about today. And he is also currently leading a LANCET Nigeria series. So he's going to address us today about the UCL LANCET Commission on Migration and Health, the health of the world on the move.
Good afternoon. Many thanks for those kind words. Yes, so I have the post-lunch shift when postprandial hypoglycemia sets in and people sleep. I'll do my best to keep you awake. So I know you've had a lot of talks on migration through the first half of this day and have discussed these issues, but I think it's important to reiterate the context. So I have a few slides that sort of sets the scene. Humans have moved largely to seek a better life and the aspiration that we all want to do better, or to flee from conflict or disaster, and it's been with us throughout our existence as a species. It's therefore not really surprising that when you critically look today, it continues to be a major phenomenon, with our estimates in 2018 is 1 billion people if you combine internally displaced people as well as international migrants. A quarter of these are international migrants. So it's a major part of the global population that are on the move, and migration and health, not surprisingly, is a critical topic. However, if you look at the numbers of people moving, while there is significant regional variation, the global numbers are actually reasonably stable. So the proportion of the planet that is on the move has remained distinctly stable, despite everything you may have had. The regional variation is such that in places such as Europe, there has been an increase in recent years of almost a doubling of the numbers, but across the planet, it's reasonably stable. The numbers ranged in our report between 1990 to 2017 at 2.9 to 3.4%. But even this peak of 3.4%, if you go back further in history, there have been many phases of humanity's history where a greater proportion of the planet has moved. Now, what this graph shows is what are the categories in which migrants move. And while we disagree with some of the categorization between labor and forced migrants, because people move for different reasons. They may start off being fleeing some violence, and eventually they will move for economic reasons to seek a better life. If you take the agreed categories, you will see that the vast majority of international migrants, the green bit, are actually labor migrants using those categories. And a much smaller proportion are refugees and asylum seekers. But as a proportion of the total, that's also each remained remarkably stable. It's important to also note that despite the anxieties in Europe, in North America, and many parts of the world that is richer, the majority of that movement is in low and middle income countries. When you look specifically at where people are coming from and focus on refugees, which is what tends to attract refugees and asylum seekers, which wants to attract a lot of attention, you would see that just 3 countries account for about half of the world's refugee population. Syria, Afghanistan, and Somalia, so in Africa and Asia. And what this graph at the bottom from our report shows is the orange bit in the middle is largely the Asian bit, which is driven by Afghanistan and Syria, and then the top bit, which has also increased a great deal, refers to sub-Saharan Africa, with Somalia driving a lot of those numbers. So why are people being forcibly displaced? You've heard from previous lectures that conflict and disasters are the key drivers. And what this graph shows is a key element of that there is a tendency towards an increase in terms of the numbers of conflicts and therefore the individuals that are moving as a result of conflict, the blue bars in the graph, but there's also an increase in the numbers of people moving as a result of disasters. The difficulty with this information is obviously the collection of information around both things are less than perfect. But what we know and what we are certain about is with anthropogenic climate change, there's only one outcome, that if we don't do something really drastic on the planet, the numbers moving out of countries due to disasters will only increase. So the future is not very good if we don't take action on anthropogenic climate change. So in reaction to all of that context and background, we convened in 2016 a group of international experts, about 25 commissioners, with careful representation from different continents in the world, ensuring gender representation in our group of commissioners. And we produced a report, which is a massive 50-tom document that you can download from the LANCET website. But we took a purposeful view that this is not necessarily a biomedical problem. And while many of us, such as myself, are medic, and a lot of my research is in infectious diseases and molecular epidemiology, that to address this problem, we need a truly interdisciplinary group. We brought together sociologists, political scientists, anthropologists, those who do research on human rights, lawyers, as well as medics and biomedical researchers, to examine the totality of the problem, and we selected subsets of areas where we went into particular depth. So I'm not going to attempt in 25 minutes to tell you about the entirety of the report. I've selected 7 key topics that I hope I will cover very briefly, some of which have been addressed in the morning and may come back in the rest of the afternoon, but I'll go through them fairly rapidly. So the first topic I'd like to address is leadership and policy. And when we examined the entirety of the evidence through a series of systematic reviews, bespoke analysis of primary data, including in low and middle income countries, we concluded that our perception that the response is highly siloed, where people are all looking within their own disciplines, is in fact replicated in different places globally, and that there is a need to look at the true determinants of health in migrants and the effect of migration on health by bringing together these multiple disciplines and addressing the siloed effect of the response. In particular, we think that the political and structural determinants of the health of migrants that are determined by the conditions that migrants find themselves before they leave, the conditions of their journeys, and what they find in their destinations are absolutely critical if we are to tackle migration and health. We also concluded that when formulating policy around migration and health, it's absolutely important that at all levels that health players and health actors are around the table when there is a general discussion around migration, which tends to focus around security. We think we need health players around the table when people are talking about the microeconomic determinants of population movement. And without that, we're always going to be on the back foot and would not address the key determinants of health in migrants. The second topic I'd like to address this afternoon is a number of myths, some of which have been touched on this morning, that have been used to demonize migrants and therefore direct the political narrative. And we do this purposely. And that's because, unlike some of the discussion I had this morning, it isn't really a neutral political landscape and isn't entirely about the health of a subset of migrants who are ill. A lot of it is purposeful, organized activity by the far right to target migration and utilize it to hamper the health of migrants, but also to pursue their political ends. So our report concluded that migrants, by and large, bolster the economies of countries they migrate to. If you look across the board globally, with the exception of countries where the majority of migrants are elderly individuals who are retired, if you look at adults, economically productive migrants, the results are repeat themselves across the planet, that the contributions are positive. In particular, if you look at high-income countries, for every 1% increase in adult migrants, there's a 2% per capita increase in GDP. And this is definitely replicated with EU migrants to the United Kingdom and similar. Those same individuals contribute to social services and the provision of healthcare as healthcare workers, where, for example, in the UK, something like over a third of registered doctors trained outside the UK. So there's a huge role for migrants underpinning the health systems as well as the economies of countries. But despite all of this, the narrative seems to focus, consciously so, on the security issues and away from all these positive attributes. Indeed, I was looking this morning on the train, And in the Financial Times, there's a published survey of migrants, and something like 70% of people surveyed believe that migrants are a burden to social services, despite about 50% of people thinking migration is positive, which is a much, much improvement compared to 3 years ago around Brexit, when it was only about 20%. The other major issue, which is the subject of the last lecture by Manuel, is infectious diseases. So of course, if you put two individuals, an infectious person and a susceptible person, and expose them, there will be transmission. That's what infections do. But as far as we are concerned, with extensive reviews of the literature, as well as analysis of primary data and molecular epidemiology, we found no evidence that migrants are leading to large outbreaks. And the simple reason is this: while diseases can spread effectively within those close contacts of migrants, outbreaks that extend beyond those are an indication of a massive failure in public health. So other than in deprived areas, in poor parts of the world, in refugee camps, where you may have outbreaks of cholera, in systems or societies with effective public health systems, we should not expect that to result in anything other than perhaps some degree of transmission to people around you, and then that should be contained. Therefore, the narrative that people use, and some of it supported by our colleagues around the global health security agenda, because we have a vested interest to increase our funding, reinforces this idea that there's somehow a massive risk. There isn't. The next element among the myths is, are migrants somehow a burden of the health system? And a systematic review we published as an accompanying paper with the Commission report last year in the Lancet conclusively said that it's about a 30% decrease, lower mortality, standardized mortality rates among migrants compared to the general population. Of course, there are subsets of migrants with higher disease outcomes. For example, those that are very vulnerable and those that do not have access to healthcare, and we should care for them. But the general narrative that all migrants burden the health system is just wrong and incorrect. And in the same way we look at homeless individuals in our cities, we should address the needs of the most vulnerable migrants. There's also a higher burden of disease for specific diseases such as infectious diseases, and that's because those are the diseases that are prevalent where they come from, and there's ongoing transmission perhaps in those specific communities. But they're all largely solvable problems and largely treatable or manageable illnesses, and we should deal with them rather than create this narrative that somehow it's a risk to everybody else. Unfortunately, the reason it continues is some individuals, such as some of our emerging political leaders in the UK, go on with this narrative that is purposeful, xenophobic and racist, that propagates the idea that somehow migrants are going to spread disease. Just not true. I'll move on to the next topic that I would address. So those are some of the myths we covered. There are several others in the full report which you can go and look at. But one of our key conclusions, which again I'm sure has emerged this morning, is if you're looking at this from the perspective of individual migrants, it's absolutely the case that access to preventive and curative care is central to all of this from the perspective of the migrant. And systems, countries, nations have signed numerous concordats, documents and other agreements that says we should provide healthcare to migrants. Yet we're not doing so. So it is our view that migrants should be included in universal health coverage. Indeed, we undertook a detailed analysis of existing health models and looked at healthcare provision with the help of health system experts, economists and political scientists, and modified a model developed by Levast and colleagues and suggested a patient-centered approach to migrant healthcare that looks at the needs at global, national and subnational level and talks about access, equity in access, as well as continuity throughout the migrant journeys. And again, feel free to have a good look at this. But we know that this isn't being done. The best example, I think, is what happened with the Windrush crisis in the UK, which you may have heard about, where our government purposely chose to destroy the entitlement records to healthcare of people from of Afro-Caribbean origin, and then turned around and said, well, they are not citizens and they should not access healthcare, with many dying of preventable causes and sometimes treatable causes. I'll move on to a different topic, human rights. Human rights is an issue, again, that many nation states have signed up to. With the exception of a minority of far-right people, most political leaders globally accept that health is a human right. Interestingly, if you look at the literature, there are so many examples around HIV/AIDS, around the provision of maternal and child health care, that people are being deprived of their human rights. In particular, the imprisonment of particularly vulnerable migrants, such as children and pregnant women, is rampant and in many countries that we found in our report. And the health consequences of this, individuals that pose no risk to everybody, are quite severe, and yet people continue. This cartoon is a child from the southern border of the US, sort of talking about being separated from their parents. And the link to enforcing detention essentially serves, as Manuel was saying earlier today, to create distrust in the health system, leaving individuals to present late to healthcare, and therefore ultimately with more severe complications of diseases that they suffer from. So the last area I'll cover is accountability. And again, here we have a very simple point and recommendation, which is all these lofty documents that global leaders come round the table to write, the global compacts, agreements, etc., are really only worth their while if there's a system to monitor with data whether we are achieving what we say we are. And at the moment, I challenge my colleagues from the UN agencies that there is no such system. So we are calling, and we will act on this, that there should be a system globally to monitor all of those commitments and to call our political leaders when they fail to deliver around migration and health. It is possible others around climate change are doing the same. We want to make sure that we hold them to account. Of course, we are academics, and so we wouldn't leave out research, especially as we found loads of gaps in the data. We believe that there is an urgent need to systematically fund a lot more research across the whole dimension of areas of research, from basic science research that underpin treatment of specific conditions that affect migrants, all the way to quantitative and qualitative population health research, as well as health policy and health economic research that allow us to better address the needs of migrants. And this is urgent and in dire need to do so. Unfortunately, many of the global funders of research do not take migration and health as a priority. It's much easier for me to attract funding for my TB work than migration work. This needs to happen, and there's an urgent need to do so. This is the last topic I'll cover in this whiz tour of our report. So, if this looks to those that do basic science research like the intracellular pathways, it's because it probably resembles that in complexity. Essentially, when we do biomedical research, what we tend to do is to stay in this box, our research box. Often we'll present it at conferences. If we go far enough, we'll do a policy brief and send it out and hope that somebody reads it. But I've taken this from our colleagues that have been more successful than us in other areas, such as climate change. And the landscape is a lot more complex. And we believe that if we are to make a difference in this area, we have to get out of our comfort zone, which is generating high-quality evidence, which we know how to do, as we did in the LANCET Commission report. But we have to use this evidence to engage the advocates, to challenge our ideological opponents, who sometimes genuinely believe that we shouldn't care for the right of migrants, to engage the media, serious influencers, and then ultimately get to society and the public if we are to change the landscape. And I'm delighted that over the last few months, we have indeed been doing so in our activity. So we've had a series of events in almost all world regions, in many nation states, including several here in Europe, in Germany, the UK, etc., where we've attempted to engage policymakers, politicians, and others. And we've produced a number of outputs over the last 12 months. We're looking forward to the future, and we're establishing a new entity called LANCET Migration, and we'll publish a report annually of LANCET Migration that generates new evidence, so does decent science of LANCET-style quality, but that we will then take to do proper advocacy and engage the appropriate communities, civil society, UN agencies, and everyone else. So I'd like to conclude here to say I have covered some of the reasons I think we should care about this topic: the humanitarian reasons, the economic reasons, the human rights issues, the underlying socio-political and moral case for migration and health. And I think we all have a duty to do better. And it's only by taking our evidence into policy and action that will make a difference on this subject. Thank you very much.